We're online.
Great. Hi, everyone. My name is Dr. Roopa Dhatt. Please give us a few minutes to get started. As you come into this webinar, we really request that all of you submit questions in Slido. And again, this is the topic, a gender responsive approach, really a conversation with the Director General. So give us a few minutes as we get started, but please submit your questions with the link that was provided on Slido. Hi, everyone. We will be getting started in a few minutes. Just waiting for everyone to arrive. If you could please kindly submit your questions to Slido. The link is provided in the Zoom and also in the invitation that you received. We just received a question whether participants will be able to participate through video call or voice. So we're actually requesting that you submit your questions again through the system called Slido. The link is attached on the side. This will be interactive, and so we will be taking those questions and interventions. Thank you.
Roopa, this is Gaudens. Could you, I think we're ready, but you can start. Go ahead, please.
Okay, great. Thank you, Gauden. Well, foremost, I would like to begin by saying welcome everyone to this very exciting conversation that's going to be taking place with the Director General of the World Health Organization, Dr. Tedros. We are delighted that this first conversation is going to be about gender and COVID-19. And on that note, I'd actually like to turn it over to Dr. Tedros to open the floor with his remarks.
Yeah, thank you, Roopa, and thank you to all colleagues attending this online and in person here. I can see many actually online. I'm happy to welcome you today to today's webinar on achieving gender transformative COVID-19 response. We're grateful to the civil society organizations, GENDRO and Women in Global Health for putting together today's program on this pressing issue. They are both our lead, and I'm really glad that civil society taking on this, especially since this is our first meeting. It's clear that the COVID-19 pandemic has gender-specific aspects, including the risk of exposure and biological susceptibility to infection, as well as social and economic impacts of the disease and response. So far, it appears that more men than women are infected with COVID-19, and men also have a higher risk of death. The reasons for this are still being investigated, and we need much more disaggregated data. Conversely, there are reports from several countries of an increase, as you know, in an intimate partner or domestic violence linked to stay-at-home orders. Women in abusive relationships face an increased risk of violence, while for many women, their care burden has increased and access to essential services has been disrupted. Public policy makers must strive to integrate gender-sensitive and gender-transformative policies into their planning and leadership. WHO is working to make sure that strong gender analysis is part of our response and preparedness programming, and that diversity and gender are reflected in our themes at every level. In May, WHO published an advocacy brief on gender and COVID-19 with 6 key asks and it's critical that together we advocate for gender equity in access to COVID-19 testing, treatment, and essential health services. For the women who form more than 70% of the health workforce, we must stand together to support their right to decent and also safe working conditions and fair compensation. This is the first of our civil society-led and developed discussions, as I said earlier. The themes of the next 2 webinars will be first, promoting the health and well-being of young people during the COVID-19 pandemic, leveraging youth engagement in participatory governance. And the second will be about social participation and accountability within and beyond the COVID-19 pandemic. WHO stands ready to work together with civil society organizations on the COVID-19 response by empowering participation, ownership, and education of communities, and by investing in society as a fundamental pillar of emergency preparedness and response. Following up on our previous discussion about resource mobilization to support your work on these topics, WHO is setting up a mechanism with the Solidarity Response Fund to provide grants for innovative projects proposed by civil societies and community groups. Now I'm happy to give the floor to my friends at GENDRO and Women in Global Health to begin our conversation. Roopa, back to you.
Thank you, Dr. Tedros. And again, we really appreciate the time that you're taking to connect with us. It really means a lot to all of us civil society organizations that you have prioritized this conversation and this dialogue. And as you've said, really this deep partnership on how we can come together. So today's conversation is not only about focusing on gender, but really about how we can put both of our thinking brains on as civil society organizations and as you, Dr. Tedros, as WHO's and the Secretariat and team on how we can really ensure that those gender inequities that we're seeing in COVID-19 can truly be addressed. So today's panelists will be both reflecting on their day-to-day realities of what they're seeing at the front line and really focusing on, what good practices, what solutions can they bring to the table that they're already doing so that you can hear directly for them what's working. But they're also here to ask from you and the rest of everyone that is tuning in today on how we can work together in partnership. On behalf of Women in Global Health and GENDRO, I really congratulate the World Health Organization for selecting the subject of gender transformative COVID-19 response for the first of these CSO meetings. And with the DG, I really thank you for taking the time for this dialogue with civil society. COVID-19 is exposing deep inequalities within and between countries, particularly gender inequality, which is deep-rooted and pervasive in health systems, and it undermines our capacity to respond to the pandemic. We have invited 6 speakers to share their experiences from very different geographies and contexts, and aim to focus on what can be done to strengthen health security and health systems in the context of universal health coverage. The headline message from this session is that health security and health for all will fail if we do not build on gender equality and gender responsive health system. This includes equal representation of women in global health security decision-making bodies. It also includes safe and decent working conditions for women healthcare workers. It includes recognition of women's unpaid work, which is happening in the healthcare sector, and also really being gender responsive in our approach to both analysis and collection of data. And finally, really supporting women's movements and organizations at the grassroots. So our conversation really today, and I do emphasize it's meant to be a conversation, is that all of our attendees, we encourage you to engage with us. There is a link that was provided in the invitation on Slido. Please submit your questions. We're excited to see that there have been already many that have come in. Include your ideas, solutions, and good practices, and your asks to all of us on how we can work collectively together. So on that note, I'm going to invite our first speaker to kick us off on the theme of leadership. Really delighted to welcome Sarah Hillware, who is the Deputy Director of Women in Global Health.
Thank you so much, Roopa, and delighted to be here. Thank you very much, Dr. Tedros, for allowing us this opportunity to present not only the issues that are pertinent to civil society, but also solutions. So on behalf of Women in Global Health and our movement, our global movement of 23 chapters, I'd like to make 4 key points on women and leadership in this pandemic and beyond. First, we've heard Women in Global Health state in other fora that women in global health, that global health is delivered by women, yet led by men, as our 2019 joint report states. Yet women hold 70% of the jobs in the global health workforce and only 25% of decision-making roles. Only 20% of the WHO COVID-19 Emergency Committee was comprised of women. Our analysis confirms the same pattern in COVID-19 decision-making, with 8 out of 10 national COVID-19 high-level task forces having a majority of men as members. A global health emergency as serious as this one needs all talent and perspectives at the table. But women are largely missing, and not just any women. Women in particular from low and middle income countries and women health workers are underrepresented, especially from LMICs. Women represent only 5% of leaders in global health. And second, having equal numbers of women and men in health leadership is not just window dressing, but it's a matter of life and death. Women know the best health systems that they manage, and they know the communities they serve as frontline workers. If women had an equal say in COVID-19, it's likely that personal protective equipment would have been designed to fit women's bodies. Women health workers would have been better protected from infection. And if midwives had an equal say in COVID-19 decision-making, we believe essential maternal health and SRHR would have been maintained throughout the pandemic and lives would have been saved. During COVID-19, 47 million women are expected to lose access to contraception, leading to 7 million unintended pregnancies. 31 million additional cases of gender-based violence are also expected. In the case of maternal mortality, we've been hearing on the ground that midwives are complaining of having been moved from maternity wards where they're needed most and into COVID-19 wards. During COVID-19 especially, we must prioritize SRHR and healthcare in healthcare settings. We can do this with women at the forefront, and we must empower women to lead, especially women health workers. Globally, in many places, it's often a nurse, a community health worker, or midwife who is the first and only healthcare provider that a patient will see. Women's lives are being saved with midwives and nurses at the forefront. In the year of the nurse and midwife, we congratulate Dr. Tedros for establishing the position of Chief Nursing Officer and for recognizing the critical expertise and contributions that nurses and midwives make when enabled and have an opportunity. There is a strong body of evidence that inclusive leadership in health with equal numbers of women and men strengthens health for everyone. As Dr. Tedros mentioned, mortality rates are higher for men. So when we integrate gender transformative policies, everyone benefits. Third, those in power who have chosen, mainly men, to make decisions on COVID-19 for the whole of society may not know the women experts, but we at Women in Global Health do. In March, we launched Operation 50/50 to crowdsource a list of diverse women experts in health security from all regions who should be included in decision-making and asked to comment on COVID-19 by the media. In the COVID-19 resolution at the WHA this past May, 130 member states committed to strengthen actions that involve women's participation and stages of decision-making processes. and mainstream a gender perspective in COVID-19 response and recovery. Yet this is not happening. As a member of feminist society, civil society networks, we'll work with WHO to deliver that commitment and support member states to reach gender parity in their national and global task forces on the COVID-19 response and beyond. We'll also work to ensure an intersectional approach, having women from diverse backgrounds by geography, race, ethnicity, disability, and other characteristics are able to contribute their perspectives. And my fourth and final point is that gender equity is everyone's business. In the case of COVID-19, men actually have worse health outcomes and higher higher mortality from COVID-19 in almost all countries. And it's been noted that women political leaders are far better than their male counterparts at responding to this pandemic. And we're not saying that women are naturally better leaders. We don't believe that women are born with an empathetic gene or that they are born with bigger ears that make them better listeners. But evidence shows that many female leaders are practicing a style of leadership that's less individualistic, more collaborative and inclusive, and more effective in building public trust. And I think one great example of that is this CSO dialogue that we're having right now. So Dr. Tedros, thank you for that. And beyond gender parity and leadership,
yes.
I'll just wrap up just one more point. Beyond gender parity and leadership, we want to see that leaders of all genders are adopting a gender transformative approach and addressing inequities that weaken health systems. We want every leader to be a gender transformative leader, man or woman, because we know that's how we'll overturn the gendered systems of power and privilege that weaken health systems in this pandemic and beyond. Thanks very much.
Great, thank you, Sarah. That was really clear and wonderful. It's not about one gender being better than the other, but really thinking about the diverse leadership and how there is leadership styles that have shown to really work in pandemic response, and really, embracing that and creating space for that. So Dr. Tedros, the challenge is to you, but we will come to you in a few minutes. I'd like to invite Dr. Amina Jama from Somalia, who is also the founder of the Women in Global Health Somalia chapter, to the floor. Amina, please.
Thank you. Thank you, Dr. Roopa, and thank you, Dr. Tedros, for inviting me in these discussions. As in most countries, and as Sarah clearly put it, women are marginalized in decision-making for us, and especially what the COVID-19 crisis has highlighted is that it highlights the existing weaknesses of gender mainstreaming practices. In Somalia in particular, we have noticed that there's a total oversight of the existing limited mechanisms for ensuring gender-sensitive policy and practice. For example, if you look at the National COVID-19 Task Force, which is made up of interministerial bodies, professional groups, INGOs, UN, and NGOs, it doesn't really reflect on who's doing the work. And sadly enough, the Ministry of Women and Human Rights are exempted. They're excluded from these task forces, despite the fact that it's made up of 9 different ministries. The Midwifery Association, the Nursing Association, all those professional that are traditionally female organizations are excluded, while we have the Doctors Medical Association, who are included. This in turn reduces the focus of the task force and limits it to only infections and mortality rates instead of tackling wider societal issues, as Sarah clearly put it, and Dr. Tedros as well. We know that COVID-19 affects women in different ways. We might not have a high mortality rate, but we have a high, it affects in the families, the tasks of the women. Secondly, we do know that women exercise leadership at all levels. So the task force in itself, most of the work is done by women at facility level, at the district level, but then they are not reflected. If you look at the task force that has been, that is public, it does not include the women who are actually working. For example, we have Dr. Dera, who is leading the call center in Mogadishu, who is a member of the Women in Global Health Somalia, but no one would use Dr. Dera talking about COVID-19 or being called upon as an expert. So those are just concrete examples. And as Sarah put it, we do have a list of women in global health experts that has been put together. It includes women from Somalia as well. So there's no excuse of not finding female experts. So what we would like as women from Somalia, and I think I speak for most of the women in fragile and conflict-affected countries, is that decision-making task forces should include or should bring to the table frontline workers, because by doing so, per automatic, then you will include females.
Yes. So Amina, we're about a minute. So
we need to listen to the grassroots voices and acknowledge their efforts, and not only fasten with what is public. So that is also something that I think needs to be acknowledged, and because then it encourages. And we do need role models, especially in our countries. If you're not seen, then you do not exist. The whole idea of tokenism and window dressing, we've had several webinars and discussions with women in global health Somalia who are representing different states and different districts, who are actually working in the task groups, but have never been called to any of the more formal decision-making tables or arenas. So I think this is something that we could work together and to change. So no more window dressing, no more tokenism. Real representation is what we are calling for. Thank you.
Great. Thank you, Dr. Amina. And your story also about how you have mobilized in Somalia. Dr. Tedros, they've put together webinars bringing frontline health workers, women in dozen numbers, sharing their stories. They've also collaborated and connected with local media to call out on when gender was not represented. Amina, you have so much to share there about the data collection efforts when Somalia was not collecting data by sex and gender. The Women's Network really mobilized and worked with the ministry to make sure that this started to happen. So that's an example of how partnership can really take place at the local level. And so, to turn it back to you to both respond to Sarah Hillware and Dr. Amina Jama, Dr. Tedros, what can we do to really, as we look at those numbers, 8 out of 10 task force are led by men, while 7 out of 10 responders and health workforce are women. So how do we get this to a more equal equation, and especially with the commitment that's come already from the World Health Assembly resolution on this? So back to you, Dr. Tedros.
Yeah, thank you. Thank you to Sarah and also to Amina. Mahassanit, Amina. Are you in Mogadishu?
Sorry, not yet. I'll be there next week.
Okay. So Mahassanit, to be honest, I don't need to respond to this. I would take it as a comment and recommendation that we need to do it. I mean, the figures are true. And the problems are, explained very well. I don't want to repeat. And you have already proposed the solution and to support, for instance, the first support member states to reach gender parity in their global and national task forces. And we will do everything to make that happen. I fully agree with what the diagnosis and also the solutions that you have proposed. And thank you so much to Sarah, and thank you so much to Amina for your very clear presentation and the asks. And one more thing, maybe what Amina said, especially in fragile countries and in conflict, like what she said in Somalia and other countries globally, we have to do even more. That's where women have, of course, more serious problems, and having them on the lead will be very, very important, because nobody can understand their problems more than them. And I fully agree that no window dressing, no tokenism. So I fully agree with the diagnosis and the solution, and we will do everything. By the way, from our side, we have colleagues listening, not just me. There is already a lot of, actually, lots of my colleagues here. Maybe can they introduce themselves so you can see also instead of me?
Of course, yes, please, Dr. Tedros, that would be wonderful to know.
And they will also, if they participate, would be good instead of just me responding, please.
Thank you, Tedros. Good afternoon, good morning, good evening. Jim Campbell, the Director of the Health Workforce Department. Wonderful to hear some of Dr. Dhatt and colleagues from Women in Global Health putting some of the evidence into today's dialogue around women in the workforce. Thank you.
Yes, hello everybody. This is Bernhard Schwadländer, Chef de Cabinet for Dr. Tedros.
Hello everyone, Samira Asman. I'm the Assistant Director General for the Division of Data Analytics and Delivery for Impact. Wonderful to see the panel.
Hello, Gauden Silberschmidt, Director of Health and Multilateral Partnership.
Hello everyone, my name is Maria Van Kerkhove. I'm the technical lead for the COVID-19 pandemic.
Hello everyone, I'm Shanaz Halabi, Director in the Office of the Director General.
Hello everybody, my name is Paul Garwood and I work in the Department of Communications.
Good morning, good afternoon everybody. My name is Taina Nakari and I think we all know each other already.
Hello everyone, I'm Sandra Kuzmanovic, Department of Communications, WHO.
Gabriella Stern, Director of Communications, WHO. Right.
And Soumya, I can see Soumya.
Yes, hello everyone. This is Soumya Swaminathan. I'm the Chief Scientist. Thank you.
Okay, I think that's it. Back to you, Roopa.
Thank you, WHO colleagues. It's really great to see how many of you are here from so many different disciplines and really keen, again, to work with you in partnership on this. And so on that note, the greatest challenge that we're facing in this pandemic is really also around the data and getting a clear picture of what's really happening. For too long and for too many decades, we've been operating in a gender blind manner. And so we're going to be hearing from the experts and the activists who have been really advocating for why gender and sex disaggregated data matters. So on that note, I'd like to turn it to both the our next speaker, but also the co-host of this conversation, to Dr. Shirin Heidari, President and founder of GENDRO, on the subject and matter of data.
Thank you so much, Roopa, and many thanks to our colleagues at WHO for this opportunity for GENDRO to co-organize this event with Women in Global Health on such an important topic. We welcome the dialogues between WHO and civil society. This is really an important opportunity for closer collaboration between the two to strengthen the evidence base for a gender transformative approach. I would like to thank you, Dr. Tedros, for taking the time to listen to us and have a conversation conversation with us. We applaud WHO and we congratulate you for your leadership in highlighting the gendered aspect of the pandemic in your communications and in the material that WHO produces. WHO's Gender and COVID-19 Advocacy Brief and the Policy Brief on Gender-Based Violence, as you mentioned, both offer valuable guidance on how to ensure an effective response, and they also underline the importance of disaggregated data and gender-sensitive evidence. Sex, gender, and age play significant roles in shaping risks of illness, death, and impact lives and livelihoods. And yet, despite these well-established and non-disputed facts, sex and gender across life course are often disregarded in research and data analysis. We welcome the steps that the WHO has taken to improve data collection. WHO's new weekly aggregate reporting form for COVID requests data disaggregated by sex and age. It also requires reporting of probable cases, another important piece of the puzzle. And the targeted surveillance study among healthcare workers aims to also capture data on gender. These are really important progress. However, we are also deeply concerned by the poor reporting by countries. Only a third of countries, of the all COVID cases worldwide, are reported to WHO with this information. We also need more granular data to have a complete picture. For example, we need disaggregated data on testing, hospitalizations, symptoms, and data on access to services such as sexual and reproductive health, gender-based violence, and mental health services. We recognize that sex and age disaggregated data are by no means sufficient to understand the complex intersectional gender dynamics in a pandemic of this scale. Still, it's a critical starting point for identifying gender-related disparities and guide future research and action. We also need qualitative research to capture the gendered, social, economic, and human rights impact of COVID on different populations. So we'd like to propose a few steps which we think is achievable for WHO to take to address the gender data gap, and we welcome suggestions on how civil society can help accelerate that process. So first, we kindly request that WHO regularly reminds member states of their commitment and obligation to report comprehensive data by sex and age. This is, of course, reported, included in your reporting form, but is also in line with commitments made through the WHO Resolution 6025. Second, we urge that any research and development supported or led by WHO, whether through ACT Accelerator, including COVAX facility or other platforms, integrates gender dimensions and sex dimensions to ensure that interventions are proven to be equally safe, efficacious, and effective for women, including pregnant women and men. All data should also be made available disaggregated by sex. Gender and other dimensions of inequality need to be accounted for when rolling out tests, treatments, and future vaccines to guarantee equitable access to those at greatest risks. And finally, to provide leadership on an inclusive approach to data collection, we recommend that WHO's surveillance system and data collection forms ensure that data on sex assigned at birth and self-reported gender include options beyond the binary of female and male. This is important to make the experiences of gender diverse people visible. Civil society partners can be important allies. We can advocate our governments to better and more regularly report accurate data by sex and age. Organizations who engage in patient care could commit to produce and report better gender data. Those who work with marginalized communities could contribute by generating evidence to make the gendered experience of diverse communities visible. And along those lines, civil society partners and academics can be valuable partners with WHO to conduct collaborative, qualitative, and quantitative research to deepen our knowledge on the many gendered phases of the pandemic. Our knowledge of COVID is being shaped by the data and research that are being produced at an unprecedented rate. It is an ethical and a scientific obligation to ensure that this knowledge is not gender blind. Gender-sensitive evidence is really imperative for equitable solution to mitigate the impact of COVID-19. I'll thank you for listening and very much looking forward to your reflections. Many thanks. Roopa, over to you.
Yes, thank you, Dr. Shirin. And you really drove home the point that data is critical, and not only that it's critical, but there are solutions, and we must act on them and achieve that. So on that note, I'd like to invite Ricardo Baruch, who is the Regional Advocacy Officer from IPPF, Western Hemisphere, based in Mexico. So Ricardo, invite you to the floor, please.
Hi, everyone. Good morning in the Americas. Good afternoon in the other hemispheres. I'm really excited to be here and also share some perspectives regarding data and gender. And I would like to start taking one of Shirin's last points regarding the fact that gender is not just about male and female, but also thinking about sexual diversity and the whole spectrum of sexual orientation, gender identities, gender expressions. And this is something that has become more and more relevant in the last few years, but we're not there yet. Like sometimes we talk a lot about leave no one behind, but the truth is that the LGBTI communities around the world are still left behind. Starting with the fact that dozens of countries around the world are still criminalizing practices of among same-sex partners and experiencing other gender identities. And in terms of data, of course, like if we're not considered like full citizens, we're not being counted. And the data around LGBT communities in general is very scarce, maybe except for the HIV pandemic, that as we know for many years, the HIV pandemic pushed many countries to start, for example, having some data about transgender women, about gay men and men who have sex with men. But apart from that, unfortunately, it's still very limited information, for example, about what's the experience of lesbian women or trans men or other or non-binary people in other areas of health. And when it comes to COVID, of course, that's also a problem because, for example, in Latin America, we've seen many, what's happening, for example, with some countries that establish quarantines by sex. So for example, if you're a man, you can only go out a few days. If you're a woman, you can go out the other days. But what happens if you're queer, or if you're non-binary, or if you're a trans person? And that's something that is affecting a lot, unfortunately, our communities. And the good thing is that, for example, in our region, the Pan American Health Organization has recommended countries to make sure that when they're using gender lens for data, they should be taking into consideration issues of sexual diversity. And for example, they should be counting and generating data about what's happening with our communities. But we know that might not be the case in other regions of the world. So in that sense, I think that it would be great if WHO can recommend other like member states to ensure that, on one hand, the rights of LGBT people are being respected, but also that data is disaggregated by, for example, sexual orientation and gender identities, which are some of the main categories that, for example, other UN agencies, including, for example, UNAIDS, are already using. And of course, something else that we think it's really relevant is that not just about LGBT rights, but other sexual and reproductive rights should be taken into consideration for generating data. We know that this pandemic has created a lot of discussion regarding, for example, what's happening with legal and safe abortion, what's happening with commodities, including, for example, emergency contraception, and what's happening with services for gender-based violence, which are things that, like, of course, we're already there, but now with the COVID pandemic, we know those things are really even more important because there are no enough services, and we're not getting enough data of information about what's happening in that area. So I think that from our perspective, from the civil society communities, we've been partnering with the UN agencies, we've been partnering with the academia to make sure that there's enough data. And of course, even if the communities are not necessarily the technical experts, these partnerships with the most affected communities, including the LGBTI community, are really important. So from our perspective in IPPF WHR, we're really trying to make sure that these alliances happen, and we're really open to continue working with you all. Thank you for your attention.
Great. Thank you, Ricardo, for highlighting the realities as well as asking us to think beyond just binary genders, but also factoring in sexuality and thinking about a more intersectionality approach to data collection. So really a clear message between our two speakers, Dr. Shirin and Ricardo, about WHO should really be urging and supporting all countries to expedite their submission and publication of weekly deaths, really making sure this is disaggregated by sex and gender, but there really is an opportunity to work in partnership with those research organizations that exist all around the world, as well as other NGOs, and really also to see this as part of core business and linking it to what already has been part of WHO's mandate in the global program work of 13 triple billion targets, as well as the SDGs. So Dr. Tedros, back to you to reflect and respond.
Thank you. Samira, would you like to say? I will
Yes.
take it after you.
Thank you so much. Rupa and colleagues, I think the point you're making cannot be made more relevant now. The need for data that is timely, disaggregated, is urgent, and I think the window of opportunity is closing. And Dr. Tedros has always said that we cannot make progress if we don't measure progress. As you mentioned, with the GPW 13 triple billion strategy, gender, equity, and human rights has been a foundational pillar. And we also have recognized that there are significant data gaps that exist because of lack of capacity in a number of countries. That is the core reason that the countries are not able to report on. And one of the WHO's primary role is to provide the technical support to the members, to its member states. We reported in the World Health Statistics report this year that a number of countries are unable to report on at least more than half of the health-related SDGs. Last week, we launched a SCORE technical package. This is a technical package of 5 interventions to improve health data in countries. And each of these letters stand for improving surveillance systems, improving CRVS to make sure that there is a stronger reporting of birth and deaths and causes of death, which is critical now in times of COVID as well, and optimizing routine health information systems, reporting in transparent way so that everyone is held accountable. And finally, the purpose of data is to use data to drive policy and to deliver impact. So we are on track, and in terms of reporting on COVID, there is already a lot of initiatives underway that we are supporting countries to report on deaths by gender and by age, as well as certified causes of death. And there is a lot of technical support that is being offered to member states. It is going to take time, but I think we ought to be rushing and investing and supporting countries in collaboration with all our partners. Dr. Tedros?
Yes, thank you. Very, very briefly, just to add to that, fully support everything that's been said, and it's an honor for me to be here and listen to you on this. I mean, not only the direct effects of COVID on gender, but the indirect effects, and you've all very well articulated all of the different impacts that we're really just starting to learn about, because this will be with us some time. With regards to the response itself and the data that we've been trying to generate, we will more strongly advocate for gender, as has been said. We continue to do so. We will continue to ask and push that even stronger to build that evidence base. Within all of our data collection systems for surveillance, through case report forms, through research studies, we ask about gender. We try to get age breakdowns, particularly so that we could really better understand the information that we are collecting, so that I could guide and inform our response going forward. within our international networks of global experts, we reach out to men and women of all different technical disciplines from all parts of the planet to make sure that we are listening and learning to each other, with each other as this pandemic evolves. And we will continue to push harder to make sure that we have more and more women as part of these global technical expert networks as well. And then just lastly, to highlight, I do appreciate the statistics around global health delivered by women, led by men. And just to highlight the efforts WHO has made to really try to put more women in leadership roles. And I am honored to work with Dr. Tedros, Dr. Ryan, and everyone here on this pandemic. Over.
Okay, thank you. So you have already facilitated the collection and use of robust data. There are 3 recommendations. Thank you, Shirin, and thank you, Ricardo. Muchas gracias. And we accept all. And I fully agree with Ricardo, especially on no one should be left behind and should include LGBTIQ communities, both in services and also data collection. So fully agree with the 3 recommendations. Thank you so much. Again, back to you, Roopa.
Great, thank you for those reflections from the team, and it's great to hear about the the renewed commitment on collecting data, and we'll be looking forward to those weekly and monthly updates on how we're making on progress and really taking that data point that right now only 50+ countries are disaggregating data by sex. Let's really get that to 193. So on that note, our next theme is really talking about what is gender responsive healthcare look like. And how do we make sure that gender responsive includes the people that are delivering the care, which are majority women. And so our first speaker is actually going to be speaking in French. So I note that there will be translation provided by the Secretariat. I invite Dr. Nicole Fouda Mbarga, who is representing the Alliance for Gender Equality in UHC, which is comprised over 110 NGOs from around the world. And she is also working with MSF at the front line as a physician and outreach public health coordinator in Cameroon. So welcome Nicole to the floor.
Bonjour à tous, merci Dr. Roopa et merci Dr. Tedros également. C'est un immense privilège pour moi de faire partie de cette conversation dont le but est de discuter de solutions pour une réponse plus équitable à la pandémie de COVID-19. Nous savons tous que les femmes, les filles, les hommes et les garçons sont disproportionnellement affectés lors des crises sanitaires. La réponse à la COVID-19 doit donc être adaptée aux besoins des filles et des femmes. Nous allons donc proposer des solutions concernant le personnel de la santé qui est à majorité constitué de femmes, la violence basée sur le genre, mais également les droits de sexualité et de reproduction. En ce qui concerne la protection du personnel de la santé, nous exhortons l'Organisation mondiale de la santé à encourager les nations à garantir la protection des personnels de la santé, qui à majorité sont des femmes, on parle quand même de 70%. Cela peut se faire à travers une couverture sanitaire totale, c'est-à-dire un accès gratuit aux soins de santé de qualité. Nous pensons également qu'un support psychosocial au personnel de santé devrait se faire. Nous avons vu des personnels en surcharge de travail, mais aussi qui devaient vaquer également à leurs tâches domestiques. Cela a eu des effets néfastes sur leur santé mentale et même physique. Il est donc impératif d'apporter un support psychosocial à travers des centres d'appel, mais également à travers des sites de prise en charge de santé mentale identifiés. À cause de cette surcharge de travail, il est également important de valoriser les femmes. Au Cameroun, par exemple, Women in Global Health a lancé le mouvement Shirin qui met en exergue les activités des femmes professionnelles de la santé qui sont actives dans la réponse à la COVID-19. Ce genre d'initiatives doivent être encouragées. Nous pensons également qu'il faudrait améliorer la gestion des volontaires qui représentent quand même des ressources importantes dans la riposte. Nous devons assurer une continuité dans l'octroi des primes aux volontaires et un retour effectif de ces volontaires qui parfois tombent malades. Ils devraient être réinsérés après leur quarantaine ou après leur prise en charge. Nous allons également insister sur l'accès aux équipements de protection qui devraient être adaptés pour le personnel. Pour ce qui est de la violence basée sur le genre, elle s'est accentuée avec la pandémie de COVID-19. Nous suggérons que la prise en charge de la violence basée sur le genre devienne une motion de l'Organisation mondiale de la santé lors de son assemblée générale. En tant qu'acteurs de la société civile, nous devons contribuer à la mise en place des centres de traitement, de réhabilitation des femmes violentées. On parle tout le temps de violence basée sur le genre, mais de façon concrète, qu'est-ce qui est fait? Nous devons sensibiliser les femmes, mais également les hommes à la recherche des solutions pour la violence basée sur le genre. Nous devons également mettre en place des centres d'appel pour la violence basée sur le genre. Au Cameroun, il y a déjà pas mal de centres d'appel mis en place. Il y a par exemple le 1511 qui a été mis en place pour les problèmes de santé mentale en contexte de COVID-19. Ce genre de ligne d'appel pourrait également être utilisé pour orienter les victimes de violences basées sur le genre. En dernier lieu, je vais me focaliser sur les droits de sexualité et de reproduction. Les droits de sexualité et de reproduction ne peuvent pas être mis en quarantaine. Il est important de maintenir des services minimums adaptés au contexte. Malheureusement, avec la survenue de la COVID-19, nous avons vu une diminution des tendances de fréquentation des services de santé en général. Nous proposons donc la mise en place des cliniques mobiles de consultation prénatale, de planning familial, d'éducation sexuelle pour les adolescents. Nous devons également mettre en place des systèmes de téléconsultation. Au Cameroun également, on a iDocta qui, grâce à un partenariat avec GIZ, offre des téléconsultations gratuites aux femmes enceintes pendant la COVID-19. Nous pensons qu'il est important de capaciter les praticiens et les accoucheuses traditionnelles qui sont parfois plus proches des malades que le personnel de la santé. Il faudra également mettre en place des mécanismes pour assurer la gratuité des soins pour les femmes vulnérables. Et en femmes vulnérables, je parle des déplacés internes, des femmes qui vivent dans les taudis, des femmes qui sont victimes de conflits ou des femmes de la rue. En dernier lieu, pour l'OMS, nous pensons qu'il est important de militer pour la distribution gratuite des serviettes hygiéniques pour un accès plus équitable. Il est également important de financer les organisations comme Women in Global Health qui luttent pour les droits de la femme pour plus d'équité dans la réponse à la COVID-19. Je vous remercie.
Great, thank you, Nicole. Merci beaucoup for your wonderful and very thoughtful, insightful frontline perspective, highlighting both the women working in health and their conditions. I mean, the numbers we are hearing is sometimes these health workers in the pandemic have not even received their stipends or any compensation for up to even 6 months in certain countries. And so this is really a reality that we must address, as well as the gender responsive components of what's needed, and to make sure essential services continue to include SRHR. On that note, I'd like to invite Dr. Denise Nacif Pimenta. She is representing a very exciting group that was formed during COVID-19 called Gender and COVID-19 Working Group, which brings together academics, civil society organizations, NGOs, and a whole slew of other actors, over 400 in this group, already mobilizing for the last 6 months on this topic. And we're going to be hearing from her on what they are seeing as good practices. So Denise Dr. Denise is from Brazil. Please welcoming you to the floor.
Hello, everyone. It's a huge pleasure to be here. Also, good morning from the Americas and good afternoon to everyone else. So, as Roopa has introduced me, I'm
Denise, we're just having a little trouble hearing you clearly. So, if the volume's a little low, thank you.
The volume is low. Let me just do it. Is it better? A little
Yeah, that's a little bit better.
Yeah?
Yeah, if you bring the mic to closer to your face, it's better.
Okay. So thank you for the introduction, Roopa. I'm Denise Pimenta. I'm an anthropologist and public health researcher from the Oswaldo Cruz Foundation, Cruz based at Brazil. And I'm really pleased to be here representing on behalf of, as Roopa said, the COVID-19 working group. So we have over 450 members that have recently come together from multilateral organizations, governments across the globe, to which the aim is to facilitate the reflection of scientific evidence on COVID-19 across disciplines and issues. So I participate in the working group also representing Fiocruz, which is a 120-year-old institution, part of the Brazilian health ministry, which operates as one of the main establishments in the country, coordinating the response of COVID-19 pandemic in Brazil. So Latin America is one of the most unequal places in the world, unfortunately. And this is especially true for women. And as we have seen in this event, especially true for the COVID pandemic. So the voices of women and women from Global South specifically must be represented. And we would like to highlight the importance of integrating academia, both from social sciences and biomedical research, government policymakers, civil society, and funding agencies in finding real-life solutions and policies for women during health emergencies. So from our experience in 2015, we put together the Zika Social Science Network at Fiocruz during the Zika pandemic. And we were able to work and learn a lot from the interaction among scientists, policymakers, and civil society through participatory research. And this was the case with associations created by the mothers and families of children affected by Zika congenital syndrome. And now with COVID-19, in collaboration with the Gender and COVID-19 Working Group, other networks in Brazil and Latin America, we also highlight social, gender, ethnic, and race inequalities in the region, and the importance of including these social markers in COVID-related research. So in recent research, especially on vaccine treatment and epidemiological surveillance, these are good examples of how research can be improved by integrating social and gender perspectives. So therefore, we respectfully ask for food to support health systems, especially in reproductive rights and maternal health at the global, regional, and national level. Historically, access to health and reproductive rights in Latin America has been central in securing women's rights as a whole in the region, especially now for Black and Indigenous women, which we've been seeing have been facing violence and invisibility in the region. We've also asked for the support of community health workers as for historical reasons as well. In the region, these are mostly Black women who are part of the community, so also play a fundamental role in mitigating the pandemic. And in turn, we as civil society and people and researchers who work with these organizations will support and aim, identify and include these experts and frontline workers from Latin America and indigenous communities to ensure meaningful engagement and representation at all levels of decision making. So good practices from previous health emergencies can help inform future and current health concerns. And in this context, we highlight the importance of trust, interdisciplinarity, and intersectorial approaches. Right? And we believe that when people come from different backgrounds with knowledge and experience come together for the same goal, amazing things can happen. Last but not least, I'd like to put forward that the Gender and COVID Working Group are committed to work and support WHO in collaborative, quantitative, and qualitative research, including the social, economic, and human rights impact of COVID-19. So thank you very much. It was an honor to participate in these discussions. Over to you.
Thank you, Dr. Denise, for highlighting some of the good practices from previous disease outbreaks, especially the importance of having networks that was demonstrated in Zika as being a source of information, but also a source of responding. And it is really great to hear about this working group and your invitation to collaborate more with WHO. One of the asks put forward and expectations that have been put forward to WHO has been the request of creating a COVID-19 and gender working group. We see this as an opportunity to have deeper connections and collaboration among what is already happening outside and connecting more with WHO. So on that note, Dr. Tedros, I'd like to turn it back to you and your team to really reflect on these various aspects from health workforce, the unique needs of men and women, and keeping health systems gender responsive and keeping SRHR as part of essential services, and really how to also collaborate across what work is already taking place around the world.
Thank you, Roopa. Jim, please.
Thank you, Tedros. Thank you very much to Nicole and Denise for your remarks and interventions there. Clearly, we're still learning much from the global pandemic and the response through this period of managing the pandemic and maintaining essential health services. We've also got to be aware of how we also look to the future to build back stronger health and social care systems, which are gender transformative. And at the same time, we have to think possibly to the near future and how we start to introduce a global immunization campaign, which will be the largest ever in the world. All of these things have an impact on what you were talking about, the health workforce. We have a health workforce which is under enormous stress, where we see absence from work due to stress-related stigma, discrimination, mental health, or through the statistics that we've seen on infections, and ultimately through death. And some of the data that we're seeing from the media, from the arts communities, who are gathering the stories of healthcare workers to go with the more regular data reporting, disaggregated reporting, but the actual stories of health workers who are giving their lives and making sacrifice is critical. If you look at this burden of work and then put it into the context of universal health coverage, the essential public health functions, the ambition of the Sustainable Development Goals, it's clear that our health and social workforce are not yet fit for purpose to respond to the population needs with the pandemic and with the additional workload that we see to maintain essential services. So we need to start ensuring that we do invest in the conditions of work, in the health and safety of the workers, to ensure that their remuneration and their conditions are appropriate, and also ensure that they're an enabling environment to deliver primary health care, universal health coverage, not only the pandemic services, and respond to what you've rightly identified: increase in gender-based violence, decrease in access to sexual and reproductive health programs for women and adolescents. So there is a huge workload in front of us, and we need to invest in the workforce to deliver on that. I look forward to the collaboration on extending the work that's already been done through the Gender Equity Hub and Women in Global Health collaboration and leadership on this agenda with all civil society to try and ensure we have a gender transformative approach to this COVID experience. Thank you, Tedros.
Thank you, Jim. Anyone else would like to add? Okay. So I will just say a few words. Merci beaucoup, Nicole. And obrigado to Dennis. I fully agree with the 4 recommendations. One is the SRHR services disrupted by the outbreak itself, and especially vis-a-vis, maternal mortality and other negative impacts for women and girls. And then the other one is on the unpaid work in health systems, mainly women, and we have to do something about that. I fully agree. And then the third is the PPE, personal protective. But in addition to that, I think Nicole also said on female hygiene and sanitation materials, which is really important. And then the number 4 is forming a gender and COVID-19 working group. We would be happy to do that. I know you can help us, and that will, bring close working relationship with us, so you can regularly, give us your support and advice. So I fully agree with that, and I will ask my colleagues here later on to, coordinate with you, so we form the working group as soon as possible and have, the benefit of that working group to move on to implement these very, very important recommendations you have already made. So thank you so much. Back to you, Roopa.
Great. Thank you, Dr. Tedros, and Jim as well, for really, spotlighting those issues. And it's great to hear the leadership, that commitment that we have. And we really also, want to take this opportunity. Many of you have tuned in, and one of the questions that was raised is, what is going to happen from this dialogue? And I hope you have already seen it is happening now as we speak. This conversation has been meant for civil society organizations to come together and put forward recommendations. We're calling it expectations from WHO, and in turn, what will civil society do, and what is civil society already doing on this area? And so some of the concrete outcomes you've already heard is the Secretariat's commitment to work on leadership, the commitment to work on data, as well as really this formation of a working group on COVID-19 and gender, because we know one conversation is not enough. And so on that note, I'd like to pull from some of the questions that we have been receiving. The very first question, Dr. Tedros, you've already alluded to, but to get more specifically, when you took up the office as Director General WHO, you expressed a strong personal commitment to gender equity. And we've heard from your colleagues of how you've appointed a senior leadership team that was both balanced by gender and geography. What more do you think needs to be done to realize your vision, and how can civil society support this vision that you have put forward at WHO? How do we make this a reality at the front lines, at the national level, and support member states? We've put forward some recommendations on how we've created resource databases and lists of who are the women experts in the space, but we turn to you on what else do you think we can do?
Thank you so much. When I agreed with especially what you said, Roopa, in the previous session, a working group on gender equality and COVID-19 with geographically diverse civil society membership, I think that working group could help actually in identifying areas of support from you to realize the vision which you have said. In the document, in the recommendations you have already made, 10 recommendations are for us and for WHO to take. And for yourselves, you have already identified 12 action points actually. Or measures, which is very important. You're actually taking more responsibility. So we would be happy to get the support you have outlined, but even on the recommendations you have made for WHO, we can work together, and then we can even expand it further and make sure that the vision which you said you have, which you have outlined as WHO's vision, could be realized. By the way, as we speak, we have gender parity, I think, at the senior management level. This is the executive management. And then at the directors level, we have, in the last 3 years, recruited more women than men. And, but of course, when you go down to P6, P5, P4, it has to roll down the whole level, but starting it from the areas where I could influence more was in order to show that it's doable. If we're committed to it, it's doable. Anyway, I take the 10 recommendations for WHO and the 12 measures which you have outlined for yourselves. And then if we have the working group, I think we can do even more than that. Thank you. Roopa, back to you.
Thank you, Dr. Tedros, and we welcome that partnership. Another question we're really receiving, and this is something that was brought up by the speakers, and especially Dr. Nicole, as you've noted in the past as well, women are majority of the health workers, but particularly frontline workers are often the first and only health professional a patient may see in COVID-19 and in health emergencies. How can we ensure the work of women frontline health workers is given the value it deserves, and that women get both decent working conditions and equally paid work? What can we do together on this particular issue? And the other panelists are also welcome to comment if you would like to put forward any solutions that weren't already mentioned.
Thanks, Roopa. Indeed, I think the contribution of the evidence that's been accumulated in the last several years, and several speakers referred to the publication delivered by Women Led by Men. Clearly, the working conditions, the economic conditions, decent work, decent labor are going to be key to this. I think one of the challenges we have now is how do we take the evidence that's been the normative work of WHO into conversations at national level with the health community, with the labor community, with the economic community, the unions, the associations. Working conditions for all workers, for all social care workers, is going to require a dialogue which is not exclusive to health. And we need to bring other stakeholders in, introducing a gender perspective, knowing that globally 70%, but in some countries, 80, 90% of some occupations being female will definitely enable part of that dialogue. And I think that's where we look forward to civil society engaging with member states and other sectors to hold those dialogues at the national level.
And thank you, Jim. And that point, especially of civil society working with other sectors to drive this agenda forward, is a really great recommendation. I'd like to actually ask the Secretariat, Tanya, I know that there are a few questions you're getting on your end as well on Slido. Would you like to propose one of those at this point in time?
Thank you, Roopa. I actually haven't been monitoring them that closely, so I would need to take just first come, first go. I've also sent them to you in case you have missed them.
So I can begin with one of the questions that also surfaced really around, particularly the question around civil society organizations have called for a WHO task force on gender equality in COVID-19. So that's been something that has been referred to as a working group. And we've heard already from Dr. Tedros that this is something that we can take on action from today onward. And so wanted to get more reflections from the Secretariat on how can such a working group support this response, and especially building back better global health. And I would, yes, go ahead, Dr. Tedros.
Sorry?
Yes, please, Dr. Tedros.
Yeah, I think the working group can do two things. One, engaging now and addressing issues related to the pandemic actually now. So you can give us your support, give us your advice to fight the pandemic in a better way. And you have already made a specific recommendation. Second, and by the way, this one could include, it's already in the areas we have covered today. For instance, your involvement in the COVAX, your advice with that. As you know, we discussed this earlier, I think the last round, we launched the ACT Accelerator end of April. And there were two objectives when we launched the ACT Accelerator. The first is to accelerate development of vaccines, therapeutics, and diagnostics. And the second objective is fair distribution. When fair distribution comes, by the way, even within a country, once products arrive at country level, there will be distribution issues. Men could have better access than women. Or adults can have better access, or adults can have better access than children. So for any product for that matter. So having the gender lens always will be very, very important. So you can help us now, including the distribution based on the two objectives of the COVAX, on the ACT Accelerator. Then going forward, we're already putting together committees. Of course, we tried our best to make sure that the panels for example, the IPPR, the Independent Panel for Pandemic Preparedness, the two co-chairs are women. That's what we have done from WHO. We appointed. Of course, the rest of the panel members will be appointed by the co-chairs themselves, and we hope they will keep the balance, the gender balance, since they have started with two. I think they should maintain that, and at least we have a parity. We have tried on the review committee of the IHR, the International Health Regulation. The membership comes from countries into a roster, actually, that we have. But we don't have enough women in there. We're putting together that committee, but it could be very difficult now. What we have in the roster is more men. That's why, as you said in your first recommendation, advocacy, especially at the national level, and from the global WHO and yourselves pushing countries to take this seriously will be very important. But we will do our best, at least to have the gender parity in other committees, although the IHR could be very difficult now to change. But what I'm recommending is these committees, the IPPR, the IHR committee, and others are forward-looking. And they will recommend, big issues on how to shape our global health system and also health security. And participation in that will be very, very important. So that's another area where the civil society can participate. So participate now on fighting, on the response, and at the same time, participate also in building the future better. Thank you.
Thank you, Dr. Tedros. And, we want to be part of all of that process. And, one of the other questions that, or themes that keeps coming up is really around the data aspect. And we've heard from our panelists of how serious this issue is and how they're trying to gather both qualitative and quantitative data. And we know that without the data, we're operating blind. A simple example is in some countries, 90% of the infections are men, which doesn't mean that men are getting infected more. It really is, giving the clue that testing is not reaching women. And you talked about civil society ensuring that access is really achieved to everybody, and we don't really leave anybody behind in all of this process. So, one of the areas we'd like to hear is how can we concretely and in an action-oriented way ensure that this gender and sex disaggregated and also the data on health workforce infections is something that we are working together to make progress on. We have proposed having a potential global surveillance on health workforce specifically, but it would be good to hear what is some concrete ways that we can make sure that this is part of the health emergency's core business.
I can take it. Thank you, Roopa. It is an important question and a proposal, and I think we should have a globally standardized protocol that can be adapted to countries in terms of assessing the knowledge, attitudes, and access to care for healthcare professionals. This can be done easily. It has been done in other areas, other topical areas, and we could partner with civil society and many of the healthcare professional associations to deploy using technology such as mobile phones, and this can be potentially rapidly done. So thank you for proposing this idea, and we will take that in consultation with our colleagues and hopefully get back to you. Thank you.
Thank you, Samara. So we're almost at time, but I have a few more questions that are coming in. We actually have many of them, so it's going to be tough to get to all of it. This is about funding, and Dr. Tedros, you talked about the Solidarity Fund and already mobilizing it specifically to have a component for civil society to put forward innovative ideas. The question is that so far more than 220 million has been raised for the Solidarity Fund. How have these been distributed in a gender-sensitive manner, and what opportunity do you see that we can ensure that this is being done, again, in a gender-sensitive manner?
Gaudens will take that.
Thank you. Thank you, Roopa. The bulk of that money has gone to commodity purchase, and I think you raised the challenge that those commodities now must be ultimately distributed in a gender-sensitive manner. We did have very strongly for refugee and vulnerable group that we were helping, and I think there the gender dimension is taken on board. But what you referred at the beginning also is, yes, we had recently a decision to allocate funding as requested by civil society to country-level civil society efforts. And there you can help us to make that from those, we'll probably have 2 countries per region to pilot to how to do that. And you can help us to make sure that some of the submitted projects for such funding come with the gender dimension. That we make sure that we have that dimension in those projects from that funding, which will go from the Solidarity Fund through WHO to civil society at country level for innovative and response projects. Thank you.
Okay, thank you. Yeah, please, Roopa.
Oh, please, Dr. Tedros, go ahead.
No, on the Solidarity Fund, as I said in my speech, civil society work will be very important. So we will take that seriously. Thank you.
We have a question coming for Dr. Soumya, and particularly the question is really on how do we make sure that integrating sex and gender is part of the research and development work that is happening through WHO and in partnership with WHO.
Thanks, thank you, Roopa. I think that's an excellent question, and it's relevant, and it's related to the other issues on data that were just being discussed. Similarly, I think we are trying to come up with some standard approaches for research methodology, starting with prioritization of research questions which are more rooted in the country needs and end user needs. In our normative guidance work in the Norms and Standards Department, also we're looking to see how we can improve the whole process end to end, starting with what the needs are at the country level and then taking it through, a good process of consultation. Who are the stakeholders that need to be consulted when we're developing a guideline, and civil society is a very important group of stakeholders. And so we're defining now the methodology and the best practices for how a guideline should be developed. And I think this process of consultation, transparency is extremely important. And then we go to the implementation at the country level. And again, this is where I think the civil society organizations play an important role, because at the ground level, you both see the reality of what's going on, and you also have a voice And in fact, civil society is what keeps governments accountable. And so raising the issues, some of the issues that have been raised today and that we've been seeing through this pandemic and even before, the disproportionate impact on women, on girls in terms of other services being impacted and on healthcare providers, women healthcare providers. I think raising the issues, making sure that it has a visibility and doing the advocacy for it. And finally, I think in the development of therapeutics, diagnostics, and vaccines for COVID, we are very, very sensitive and cognizant to the fact that data on women and children is extremely important. It's often neglected, particularly data on pregnant women. Pregnant women are often excluded from clinical trials. And we want to set an example, at least in the studies that WHO is supporting, that women and also pregnant women should be considered and they shouldn't be left out, and in all kinds of research, but particularly in product development. And as we go forward with the 3 pillars of the ACT Accelerator, I think it's going to be critically important for when these new products are ready for delivery at the country level, that the gender aspects are kept in mind, and our country delivery team, I think, will benefit a lot from interactions with this group. Thank you.
Thank you, Soumya, for those reflections and concrete ways of how we can work in collaboration. So we're at time, and I want to take this opportunity to say a special thank you to WHO, especially the Gender Equity Rights team, and for the Health Workforce team and the partnerships team for putting this together. We know this is first of many, and this is an opportunity for us to learn and improve the process. So encourage all of those that have tuned in on how we can do more to make this solution-oriented and more action-oriented. We've released what has been our the 10 points that Dr. Tedros has talked about our expectations for WHO, as well as the 12 actions that civil society has agreed to do. We know that this is meant to be a dynamic process, so encourage you to continue to submit those things. And I want to end by stating that we're not asking for anything new. Everything we're asking for has already been agreed by member states in the SDGs, in the Political Declaration of Universal Health Coverage, and other global agreements. But we know that progress on gender equality has been far too slow, and it is estimated that it's going to take us 200 years. We currently know that women contribute $3 trillion annually to the health sector, and half of that is unpaid. These are all realities we must change, not only because it's the right thing to do, it's a smart thing to do. And we know that at the end of the day, health security is a critical part of universal health coverage, and primary health care is part of that process. So let's really make sure that even during a health emergency and pandemic, we continue to really approach this in a gender transformative manner. So on that note, we have released what those points are. There's a link already provided, and we'll be distributing it widely. And I'd like to give the final words to Dr. Tedros and WHO to close out. Thank you.
Yeah, thank you. Thank you so much, Roopa. That was, the closing, excellent. I fully agree. And I will only add one thing to what you said, or the overarching recommendation you made, which says, it's number 10, bring a gender perspective into every dialogue hosted by WHO. I think that's the most important one. Everything starts from listening, from dialogue. So we will do that. Thank you so much for your support, and look forward to working with you even more closely and make a difference. Thank you so much.
Thank you, everyone, both on behalf of Women in Global Health and GENDRO.
Thank
Bye-bye.
you for your leadership, Roopa, and thank you to all your colleagues.
Thank you, Dr. Tedros.
Thank you, Shirin.
Thank you.
Many thanks. Thank you so much.
Merci beaucoup.
Thank you.
Obrigado.
Bye.
Thank you again for the time, all the speakers, and Dr. Tedros. Well chaired, Roopa, and looking forward and exciting collaborations after this.
Yeah, a lot of work to be done.
This is just the beginning, obviously, absolutely. Thank you so much, everyone.
All right.
Great. Thank you.
Bye, everyone.
Bye.
Have a good day. Bye-bye.
Bye-bye.